Good morning, everyone. Welcome to this Class 2 Clinics case series presentation. And today's case will be presented by Ms. Soumya Panda, optometrist from our Bhubaneswar campus. This case will be moderated by Dr. Srikanth Kumar Padi, vitreoretinal surgeon from the Bhubaneswar campus, and Dr. Deepak Kumar Bagga, who is an optometrist and consultant optometrist working in the low vision clinic at Hyderabad campus, joining for this session as a moderator. And for the panel discussion, we have Mr. Sujay Kumar Mukherjee, an optometrist from Bhubaneswar campus, joining for the panel discussion. I welcome Dr. Srikanth Kumar Padi and Dr. Deepak Kumar and Mr. Sujay for the case presentation. And I request all the participants to drop your questions in the chat box. These questions will be addressed by both the presenter and the moderator in the panel towards the end of the presentation. With this short introduction, I'll hand over to Soumya Panda and wishing you all the best for the rest of the presentation, Soumya. And you can start now.
Good morning, everyone. So today I'll be discussing a case with Stargardt disease and its low vision rehabilitation management. So the learning objective of these sessions are diagnostic modalities for Stargardt disease, functional implications of Stargardt disease, and approaches to manage a case with low vision. So 19 years male from Dhenkanal, Odisha, presented to our clinic on 7th June 2022. On presentation, he has a defective vision for distance and near since 12 years and using spectacles since 2 years and presently discontinued. There is no other significant ocular and systemic history. There was a prior local consultation and he was diagnosed as macular dystrophy 2 years ago. And he has a positive family history. His sister had similar eye problem. So in clinical examination, his unaided visual acuity is 2200 in both eyes and near vision is N18 at 25 centimeter. In refraction, we got minus 0.5 diopter spherical. With that, there is no further improvement in vision. Ocular motility and position was full and free, and the position was ortho for distance and near. On slit lamp examination, all the anterior segment findings are within normal limits, and IOP was 12 mm of mercury in both eyes. However, the dilated fundus evaluation shows macular scar with atrophic patches with RP changes. So based on these clinical findings, he was diagnosed as macular dystrophy and some retinal investigations like autofluorescence, OCT, ERG was advised, and he was also referred to Institute for Vision Rehabilitation for further management. Now I'll request Dr. Padi to describe all the fundus details and the investigation report, what we find in this case and what are the findings for Stargardt disease.
Soumya, I don't see Dr. Srikanth join the session.
He's there in the panel. Yeah.
Okay. Okay.
Yeah.
Okay.
Yeah, just before going to the investigation per se, just I want to go to the chief complaint. Soumya, can you go to the slide number 1? See, whenever we are seeing such retinal dystrophies, the chief history may be different for different retinal dystrophies. For example, in a case of retinitis pigmentosa, what we see more often in our day-to-day clinic, the most common difficulty is nyctalopia. That is difficulty in evening time vision, and the patient starts difficulty at the evening time. The second most common chief complaint is whether the defective vision is central or peripheral. So in cases of retinitis pigmentosa, the defective vision is mostly peripheral, whereas the case what we are discussing, the defective vision is central. So it is very, very important whenever we are taking clinical history, we should take a note whether that difficulty or defective vision for distance and near, is it central or is it peripheral. So typically Stargardt disease, they present with central loss of vision, and the vision in the early stage, it nearly remains like better than 20/100. And in the moderate stage, the vision decreases up to 2400, and in severe cases, it can go even up to counting finger type vision. The second most common complaints in such patients are delayed dark adaptation. So one has to ask the question that whether when someone goes from bright to dark, so is there any delay in the adaptation? For example, while going to cinema hall, so are the patients facing any sort of difficulty? Okay, so most of the cases, the peripheral vision remains normal. It is the central vision or central scotoma, which is the initial presentation of Stargardt disease. Why this is so in Stargardt disease? Because the primary pathology, it is a form of macular dystrophy, and the primary pathology lies at the macula. That is why the central vision gets affected initially. So as the disease progresses, other part of the retina gets involved, it may affect the peripheral vision, but that is always seen in the advanced stage of disease. Okay, so let's go to the fundus picture.
Sorry, Dr. Shrikant. Shrikant, can you switch on your video so that audience can connect with you if possible?
Yeah, just a minute. Actually, I'm having difficulty in my camera. That is why I'm not able to.
Sorry for the fine.
So as a routine procedure, what I do in all dystrophies cases, I do autofluorescence, I do optical coherence tomography, and finally electrophysiological tests. So electrophysiological tests can be in the form of electroretinogram or electrooculogram based on the merit of the disease. Okay, so why autofluorescence is important in retinal dystrophies? So most of the retinal dystrophies, they generally affect three layers. First is layer of photoreceptor or layer of retinal pigment epithelium or choroid, or it can affect multiple layers simultaneously. That is either choroid or with RP and photoreceptor both. So what autofluorescence gives? Autofluorescence actually gives the idea about the functionality of retinal pigment epithelium. Okay, so if the retinal pigment epithelium is affected, then you might get a abnormal autofluorescence. The hyperautofluorescence or the normal autofluorescence is imparted by the retinal pigment epithelium and the lipofuscin which is present inside it. So any abnormality, any loss of retinal pigment epithelium, you might get a hypoautofluorescence. Whereas any hyperplasia or any extra accumulation of lipofuscin in the RP, retinal pigment epithelium, in those cases you will get hyperautofluorescence. So whenever I'm saying hyper, it means that more white. Whenever I am saying hypo, it means that it is more black. So if you see the autofluorescence image here, the disc which is normally hypoautofluorescence because there is no retinal pigment epithelium over the disc. The macula where the normal RP autofluorescence is kind of not visible due to the overlying lutein and zeaxanthin in the macula, it is also hypo. So on autofluorescence, normal autofluorescence image, the disc and macula both are hypoautofluorescence. And the blood vessels, because presence of hemoglobin pigments, these are also hypoautofluorescence. So which is here we can see the macula, the disc and the blood vessel are hypoautofluorescence. So what happens in Stargardt disease? There occurs loss of outer retinal layers of the macula at the macula. So primarily the disease initial part of the life, the disease affects the macula. So outer retinal layers means it is the retinal pigment epithelium, photoreceptor and external limiting membrane. So these are the three layers which are primarily affected in Stargardt disease. So once the RP gets affected, the already normal hypoautofluorescence of the macula, it gets exaggerated. So you get a dark exaggerated hypoautofluorescence at the macula, which is well demarcated. So if you see a well demarcated coin-shaped hypoautofluorescence at the macula, this mostly indicates there is loss of retinal pigment epithelium at the macula. In addition, what we see, you see few hyperautofluorescent. So can you point hyperautofluorescent speck-like thing, which is typically sparing the disc. So if you see, there is no hyperautofluorescent in and around the disc. So there is peripapillary sparing, whereas you see a few hypoautofluorescent along with hyperautofluorescent. So what happens? These are nothing but retinal flecks. So what happens in Stargardt disease, the typical or the sine qua non is the presence of retinal flecks. So retinal flecks are nothing but accumulation of lipofuscin in the retinal pigment epithelium. So I told you it is the lipofuscin in the retinal pigment epithelium which imparts the fluorescence. That is why you see those hyper autofluorescent, which corresponds to the retinal flecks of the fundus photography. So how these flecks develop, and you see few hypo and hyperflex also. Why that it is normally known that the flex should be hyper. So why few flecks are hypo and few flecks are hyper? So it is a degenerative RP. If the fleck gets accumulated in the RP for longer time, the RP gets degenerated. So these are the old or degenerated RP which imparts the hypoautofluorescence. So how? So typical picture is presence of a central macular atrophy and hyperautofluorescent flecks are the characteristic feature of Stargardt disease. So this is what. So why I need to do autofluorescence in a case of Stargardt disease? The main reason is to look at the extent. So in most of the cases, like if you go to the fundus picture, it is very. Please go to the fundus picture. So in this case, it's very difficult to make out flecks. So one can hardly make out flecks in the naked eye, but the flecks can be better appreciated in the autofluorescence imaging. And you see one characteristic feature of flecks in Stargardt disease is like it grows centrifugally. That is, the flecks appear from the disc. It starts at the disc or the posterior pole and then extends towards the periphery. So the centrifugal pattern of the pisiform flecks is the characteristic feature of Stargardt disease. Okay, Soumya, you can ask some of your students to describe the optical coherence tomography image also.
Sujay, are you there? So now I'll request Sujay to explain the OCT and the ERG.
Hello, am I audible?
Yes, Sujay, you're audible.
Yes,
Please
yes. So thank you, Dr. Srikanth, for describing all the parts of all the components in Stargardt case, starting from the classification as well as the clinical features in particular areas like if OCT, autofluorescence, fundus photo, and ERGs are concerned. So let me take you through this OCT once again. Now, in this particular case, we already have performed all the diagnostic evaluations to replicate the final outcome of that disease part. Now, there are certain features which are to be explored and that Dr. Srikanth already pointed. Now here this OCT findings of both the eyes. Now let us focus on the left eye because both the eyes look almost similar. Now this fundus photo, that color one is the color fundus photo, and the next to that fundus photo there is a greenish hue, and at the center there is a bluish one. So it is particularly a geographic map that shows that elevation depression map, just like our OBSCAN does. Now, at the bottom of that particular two fundus images, one is the color and one is with the elevation depression map. The first one is the OCT scan, which is taken horizontally, and just bottom of that, which is taken vertically. Now, just at the right hand side of that particular image, that greenish hue again, that points a lot of scalar values like 204, 214, 172. Those are nothing but the calculation as per the machine, the overall thickness of the retina, starting from the internal limiting membrane till RPE. Now at the center, we can see the greenish hue, which is also there while we explore that ups and downs of the retinal area. That is because of the foveal depression. So that is that 172 micron that comes. But usually, if we compare that thickness from our baseline normal data, age-matched normal data, that is this data is bit down. It should be around 200 to 240 micron if that healthy individuals are considered. Now here it is about to be 172. So that is what we can say, that fovea is bit atrophied, or the foveal contour is bit depressed. Now, if we again look at that OCT map, OCT scan, that one is one that shows a 1, another one shows that 7, that the left hand side of that left eye, that is the scan image that shows there are some points which are to be considered, starting from the first one. First one is the vitreoretinal interface. We do not see any reflectivity there, so that is what that is normal vitreoretinal interface. Now the foveal contour. Now here the contour that we can see based on the scalar values, that is 172, usual it should be 200 to 240 micron. So the foveal contour is a bit depressed. Now consider the intraretinal layers. How is the structure of the intraretinal? As of now, this intraretinal layers appear to be okay, so preserve intraretinal layers. But if there are multiple features which if we can zoom that image, we can see there is the photoreceptor, absence of photoreceptor layer, absence of ellipsoid layer, RP is bit atrophied, hence we can see much of the choroidal layers. So that is what the choroidal reflectivity, just bottom of the RPE layer, at the very hyperreflective band, which is seen. Soumya, can you please point out that over the RPE, we can see that hyperreflective band. So this is bit atrophied, or it is degenerated. Hence, we can see more of the choroidal areas. So the retinal thickness appears to be going to be a bit thinner. So if we perform any functional test like ERG kind of, that would be a bit down if we correlate that both together. Soumya, okay. Hello, am I audible?
So you're audible.
Okay, so Soumya, can we continue in the next slide as well? Yes. So as we already have correlated, and if we also take some points of Dr. Srikanth, that he told that in Stargardt's, usually photoreceptor rods and cones are minimally affected, but it is more if cones are affected in case of macular degeneration. Now, in our case, what did we see? We did see that OCT image that showed reduced contour, reduced thickness at the level of fovea. So we anticipate that photoreceptor cone function would be more down compared to the rod function. And here we can, if we now look at the rod and cone function based on ERG, what we can see that right hand side image is from the it is the right eye and left eye all together. Now here the first one, the first image towards at our left hand side, that is done in the photopic condition, means light adapted condition, and the left hand side, it is done in the scotopic condition, means dim light adapted condition. Now first one that showed the cone function, the first one is the photopic 3.0 ERG, and the bottom one is the photopic 3.0 flicker. Now what does that mean? 3.0 3.0 is nothing but the 3 candela per square meter. That is the intensity of light if the patient is being adapted in the light adapted room for next 10-15 minutes or so. Now while we made it functional, so we can see the response. The first one is the cone mediated response, and the bottom one, the flicker, is the only cone mediated response. Now if we compare the data in terms of amplitude and implicit time wise, we may not see any deviation, but amplitude wise, that is obviously.
Sujay,
yes,
you asked Soumya to point out what you are like. We are kind of we are going all over the image. So if you can point out which graph or which part of the image you're talking. So
which one? Okay, Vijay. Now, Soumya, can you please use your cursor towards your left-hand side image? Yes. The bottom one is the flicker one, that is 3.0 flicker, and the upper one is the 3.0 ERG, the upper graph. Yes. Now that both shows the function of the cone. cone mediated response. Now we can see if we compare the amplitude with the age match control, we can see that is a significant decreased response in this photopeak part. Now, if we now focus on the scotopic, means a dim light, Soumya, use your cursor, yes. That is a scotopic 0.01 ERG, that is 0.01 candela per square meter light was used, intensity of light was used. And the bottom one was scotopic 3.0 ERG. Now, this is the mixed response. The first one, 0.001, is the cone rod mediated response. Now, here what we can see, that is also a reduced response if we compare with the age match control, but that decreased response is less compared to the photopeak response, which is decreased. So, which is because of both the rods and cones are equally affected, but cone intensity of cones are much affected compared to the rods because photoreceptor cones are mostly present at the level of fovea. Okay, so based on this response, we can say the responses are a bit down in both the scotopic and photopic, but photopic responses are a bit affected, involved compared to the scotopic one. Soumya, can we go to the next slide?
Sujoy,
Yes.
Amit here. Just a quick point. If you, Soumya, could go to the previous slide. I thought I will just also orient people. The vertical bars that you would see are the reference values, not that one. The next one, the next one, yeah, that one. That one is the reference range that is given, and that is for the B wave amplitudes. And if the small one, if you see on the left side, a little bit on the left side, yeah, that one is the A wave reference range values provided by the manufacturers, and the whatever the patient values is being compared to that range, and based on that you can see the classification that goes whether that is in the red range or in the green range, and those values that are matching with the reference are highlighted in green, and those that are in the border, which is the 2.5% of the reference range, are marked as red. You can see the reference distribution, how they have done. And same way for the all the other waveforms. Here only the for each of the waveforms, we look at amplitude and the latency or the peak time. So if you see for the photopic 3.0, the first panel on the left side, the top panel on the left side, the responses, the amplitudes are reduced, especially for the right eye, but the left eye, it looks near normal. There is like only one highlighted region that is actually showing in red, correct? And as of so in that, actually there is a wave and B wave. Largely A wave is contributed by photoreceptors and the B wave is from the bipolars. And if you go to the cone bipolars, and if you go to the bottom panel on the left side, the flicker responses for the left eye is near normal. It is not like fully abnormal. If you see, it's close to the edge of the reference range. Whereas in the right eye, it's much more reduced gap between the reference range and the amplitude. So this is cone bipolar response that you would get from the flicker responses. And similarly on the right side, the first panel is only scotopic responses. The dark adapted 0.1, 0.01, only scotopic, and it is actually close to the normal values, little bit below the amplitudes, and also the latency is also little off. And the bottom panel actually gives the again the photoreceptor and the bipolar response, and most of them seems to be touching the reference range. So there is indication given in most of them in red and a couple of them in green. So this color coding actually also tells us where the patient is actually lacking, whether it is in amplitude or latencies. Yeah, that's all I wanted to add. Continue, Sujat.
Thanks, Amit. And Shrikant, you raised the hand. You have any question or any
Yeah,
comment?
yeah, I have just one comment. Like,
Yeah, please.
yeah, for the audience, like we are discussing ERG, and these are difficult investigation to interpret. Just to tell the audience that ERG, the graphs that we are seeing right now, this is nothing but full-field ERG. So full-field ERG assesses the global retinal function. Okay, so in Stargardt disease, what happens? Stargardt disease is a localized disease to start with. So as I told, it primarily or initially involves the macula. So that is why in full field DRG, you may not get any changes in the early stage of the disease, because full field DRG assesses the global function. And where the disease is localized to the macula, you may not get any full-field ERG changes. Whereas in advanced stages, you may get both scotopic and photopic, that is both cone and rod mediated responses getting affected. So in our case, where you see you kind of intermediate stage of Stargardt disease, where the global retina is not affected, but the macula and up to mid periphery, the retina is affected. That is why we are not getting completely flat scotopic or photopic responses. We are getting kind of subnormal scotopic and photopic response. So this is my point for all the audiences, that so that is why the classification of Stargardt based on ERG is met. So initial stages of Stargardt, you may not get any ERG changes, whereas in early stages, you may get flat responses. So based on this, they have classified Stargardt disease on the basis of ERG into 4 stages. So that's from my side. Sujay, you can describe. And
Right. Thank you, Dr. Amit and Dr. Srikant. Now we are at the verge of our ERG report. This is scotopic 3.0 OPS. OPS means oscillatory potential. That does reflect the response from the amacrine cell, which is in the mid-retinal border. So this amacrine cell response we do not measure. We just see whether it is present or absent. In terms of presence, we can determine that whether the presence of the amplitudes all are present in a normal preserved manner or in a reduced manner, usually. So it consists of a B waveform followed by multiple B wavelets. It does not contain any A wave. That should be multiple ups and downs. We can see multiple ups and downs of that particular waveform that is seen usually. Now in the right hand side and the left hand side, we can see multiple lumpy bumpy appearances. So based on that, a person cannot even judge whether it is present or absent if such report comes. See, that happens because we used a skin electrode. We used a skin electrode that is not, this system is the LKC handheld device. We forgot to mention that in the beginning, but it is not our Metrovision device, tabletop device. It is LKC handheld device. So here we use a skin electrode, and we know that if we use a skin type of electrode, we can see artifacts. We will generate artifacts notoriously because it is conformed over the skin. But on the other hand, while we use the contact lens electrode, because of the polarity of the cornea, contact lens electrode does give you more amount of original response, authentic response. So based on this graph, it is not ideal, it is not wise to mention whether the response is present or absent, but we can say it is hard to determine whether the amplitudes are formed or not. But based on the scotopic and photopic amplitudes, oscillatory response should also be present, but in bit reduced manner if we consider the earlier 2 graphs in the photopic as well as in the scotopic phase. Over to you, Soumya.
Thank you, Sujay and Dr. Pandey, for your this description of ERG and fundus. Now we'll move to the H wave. This is the right eye. This is the H wave of the patient, which show there is scotoma and means depression point in central field of the patient. And now coming to our case, this is the picture of Dr. Carl Stargardt, who first described and first reported about the condition in 1909. And this condition is inherited recessively, and it is the prevalence is 1 in 8,000 or 10,000 in the population. Actually, there are some pictures.
Bye. Atipani Kori.
Soumya, we lost your slides. Are you resharing?
Yes, yes.
Oh. Dr. Shrikant, in the meantime, the chart, whatever you answered, the chart box is only visible to those who are in the Zoom platform. A couple of them are in fact, most of them are also on the YouTube platform. So
Okay.
if you don't mind, if you can take these questions and if you answer, so it will be good for the audience.
Yeah. So there was a question from Prenandini. So what will be the indication for sending a fulfilled ERG or multifocal ERG? See, the Stargardt disease is mostly a diagnosis of clinical, based on clinical symptoms and clinical features. So ERG, what ERG? ERG extra aids in looking at the extent of the disease. So as I told, the classification of Stargardt is based on ERG. So to know the extent of disease, ERG may help in Stargardt. And for me, multifocal ERG can help in two conditions. First is in Stargardt disease, due to affection of macula, these patients, they do develop eccentric fixation. Most eccentric fixation are mostly superior what has been described in the literature. So MFERG may help in localizing the eccentric point of fixation. And second point is that the depth of involvement of the macula can be assessed with the help of MFERG waves. So these are the two conditions, but it's not mandatory to do MFERG in all cases of Stargardt ERG. And one more question is that the role of pattern ERG in Stargardt disease. So pattern ERG generally tells whether the disease affects the macula or a disc. So since this is a clear-cut diagnosis, so pattern ERG generally we routinely do as a protocol before the fulfilled ERG to look and to confirm our fulfilled ERG findings. So this will only tell whether there is affection of disc or macula. Since these are clear-cut diagnosis, so one may not get extra information from pattern ERG. So for me, fulfilled ERG is must for Stargardt disease to look at the extent of retinal involvement.
Thank you, Dr. Shrikant. Soumya, you ready?
Actually, I have put some pictures of this, but I don't know if this is not supporting here, but it was there in my presentation.
Okay, so maybe ignore that. Can you move forward with the presentation?
Actually, here I have described some photograph of Dr. Erika Chanduri, who has who is also has a similar Stargardt condition, and she by her art he gave the visual problems she had she had her own visual experience through this visual art. I'm sorry, I'm unable to show the pictures for it to everyone. So, the main implication of this visual impairment can cause severely reduced quality of life This paper was published in 2013 by Dr. Gothal et al. And it involves quality of the quality of life can be reduced due to the emotional distress, anxiety, and depression. So now coming to our case, a patient was visited to our Institute for Vision Rehabilitation on 25th June, and we have he has accompanied with his mother and uncle. Presently, he is working in an electrical shop and discontinued his study because of vision problem. So these are the activity limitation from his side. He has difficulty in copying from blackboard and recognizing faces, watching TV and computer work, and also in near work like reading small prints and college books, bills and price tag. For that, due to this difficulty, he discontinued his education. So now coming to his high contrast visual acuity, it was 2200 in both eyes, and the low contrast visual acuity with Kelly-Robson chart is 0.60 log and 0.75 log, which is reduced compared to the normal value. And in near vision, his reading N12 at 12 centimeter, refraction was 0.5 diopter spherical, and there is no improvement. And the color vision for both eye, it is normal with both ECRA and D15 test. So now we have calculated the magnification required for assistive devices for distance, and the magnification is 5x for distance. We have showed 2.1x binocular spectacle and 5x monocular handheld telescope. And patient prefers the 2.1x binocular spectacle for spot viewing. And this is the required magnification for near. We have used the formula equivalent viewing power. Here, the formula is best corrected near visual acuity divided by target near visual acuity 100 into working distance. So here the patient's near visual acuity is 12 and the target visual acuity is N8. So we fix 3-line result, that is N4, and the working reading distance is 12 centimeters, which gives us 6.25x magnification for near work. So these are the some we tried 6x cutaway stand magnifier and 2060 LED stand magnifier for trial, and patient prefers the 3.5-inch display portable magnifier, and we have suggested, in plan of and management, we have prescribed some device and we have suggested some points. The suggestions are approach magnification for reading and watching TV and face recognition will not deteriorate his vision. We counseled him, and we also discussed the contrast enhancement measures like use of extra illumination, felty pen, which can improve the contrast. And for computer work, we demonstrate the inbuilt screen magnifier and suggested him to use this screen magnifier for independent computer work. In prescription, we provide a 2.1x binocular telescope and 3.5-inch portable video magnifier. And we also provide 100% vision impairment medical certificate based on his visual field, which is less than 10 degrees. And we asked him to review after 3 months. So the follow-up was done after 23rd September, which is an online consultation, and we asked about the visual condition, and patient was comfortable with the device which was prescribed from the previous visit, and with the help of this assistive device, he joined in the college, and now he's doing his graduation and also managing his part-time job in electrical shop. So the take-home message is vision rehabilitation service facilitated in improving the person's participation in detail. Losing vision doesn't mean losing independence.
Okay, thank you, Soumya. Soumya, can you see the Google spreadsheet? Any questions there? And
Dr. Shrikant has raised his hand, so maybe we'll.
Yeah, I have one question. Like, you guys perform a reflection day to day for retinal dystrophy patients. Like, any sort of like what has been reported in the literature that in best vitaliform most of these are hyperopic. Like, is it also true that in Stargardt disease these are mostly myopic refractions? And my second question is that, is there any particular trend of color vision difficulty in Stargardt disease, like that you have noticed in your clinical practice? These are the two questions from my side.
Deepak, you want to answer?
If you look at the refractive status, we have not studied specifically that, okay, in the Stargardts, what kind of, but yes, the a couple of patients who had significant refractive error, they opted or preferred using contact lens for better visual outcome than the glasses. Probably because that allows them to have better eccentric viewing, and then as compared to with the glasses, because in the glasses, if you're using eccentric viewing at times, it's not as effective because of the peripheral aberrations and other things if they have significant refractive error. So therein contact lenses play a major role. So that is something which can be considered. And similarly, the color vision deficiency also, all patients may not have color vision deficiency, but the pattern also, we have not observed any specific color vision deficiency pattern. So maybe that is something which is important for us to look into the literature, and then if we record in patients, we can retrospectively look at if any specific pattern was observed. I'm not sure if Amit has something to add here.
Not really, Deepak. We have not actually looked closely at these patients and did the analysis of sorts to see if there is any specific color vision loss. But yeah, we haven't done that. If we have a closer look at the files and go back and see, then we can probably see, at least from HRR classifications, whether they failed the blue yellow plates or whether they failed only the red green. So those kind of things can be identified.
Yeah. A couple of points from what Soumya you presented. So you mentioned LCVA, and then you presented the contrast sensitivity measured with pelidopsin. So people need to differentiate the CS, or the contrast sensitivity that you measure using pelidopsin. It gives you contrast sensitivity, not the low contrast visual acuity. So there is a difference when you say low contrast visual acuity. So therein what you are measuring is basically the visual acuity at lower contrast level. So there are low visual acuity measurement charts that are available at different contrast levels. It can be available at, say, 12.5% contrast, 10% contrast, 5% contrast, or 2.5% contrast. So it's uniform contrast at that level. What is the visual acuity performance? That is what you are measuring at. So and then you compare it that, okay, in high contrast acuity, if the performance is person can read 20/200, how many lines person can read? Can person still reach 20/200 at low contrast levels? So if I'm measuring at 10% contrast or 5% contrast or 2.5% contrast, if I'm reducing the contrast levels, how the acuity, visual acuity compares it with the high contrast. So that is what comparison usually done. And then some of the literature suggests that, yes, if you're measuring on 10% contrast visual acuity, then 2 lines difference is considered normal. More than 2 lines difference. So, but these are the not direct measurement of the contrast sensitivity, But yes, what you're looking at the lower contrast level, how the acuity performance would be. And that may be indicative that, okay, person is having impaired contrast sensitivity if there is a difference of more than 2 line between high contrast visual acuity and low contrast visual acuity. And these are again usually done for the convenience because or the cost consideration, because low contrast visual acuity charts are economical or cheaper as compared to the contrast sensitivity measurement tools like pelliropsin. So if you have pelliropsin available, if you have measured, so then that is contrast sensitivity, that is not the low contrast visual acuity. So people should not get confused between the two things, and both are not interchangeable. Both give you different measures of the visual functions. The other point which I had was that you mentioned that 100% impairment based on the visual field less than 10 degree. But if you recall what Dr. Padhi mentioned and what was shown in the visual field test report also, that peripheral visual field is not affected in these cases. It's only the central field loss. And when you're considering visual field for preparing a medical certificate, therein you are considering the peripheral field loss, not the central field loss. So if only from the point of, because if you see that it says that the extent of visual field from the point of fixation, to what extent maximum they can see. So if you see the peripheral visual field was intact, it's only the central field loss. So therein you would just consider based on the visual acuity, not based on the visual field loss. So in such cases, based on the acuity, if I go by 2200, if that is the best corrected acuity in each eye, then person would be eligible for 40% impairment, not the 100% impairment.
But
Okay.
if in 10 degree, 10-2 also, if the scotoma is involving the 10 degree field, then also we provide it based on the visual acuity?
Yes, yes. So we just don't look at 10 degree visual field in isolation. You have to look at say 30-2 or 24-2 also, or in the confrontation also, if you see that yes, person can, so there's no problem with the mobility, there's no advanced field loss, then you don't consider that. Then central scotoma, because most of the patients who have say parafoveal telangiectasia or macular edema, macular scarring, if you do the 10-2, you may find relative or central scotoma. So 10 degree would be affected there. But it may not be that much disabling as compared to when somebody is having say advanced peripheral field loss because of retinitis pigmentosa, because of glaucoma, optic atrophy, or even in case of hemianopia.
Deepak, there's one more question from Ankita Mishra. While dispensing a low vision device, do you train them on eccentric viewing also?
So there are reports which suggest that yes, eccentric viewing training is helpful. Okay, so now what you need to consider is, when do we consider giving eccentric viewing training, and what is the implication of it? So most of the time, like in this specific case also, so when you say juvenile macular degeneration, Stargardt's or heretomacular degeneration, so if person is having this ocular condition or visual implication, visual impairment for more than 6 months or so, usually they will find their preferred retinal locus naturally. So they are all automatically trained. Naturally, they are trained, and at times in their Amsler, when you are plotting also, you may not find any scotoma. They may not be able to identify because they are seeing through their preferred retinal locus, which is also called PRL in short. So if person is already trained, then you don't need to provide any additional training. But those who have recent onset, say in patients with age-related macular degeneration, wherein somebody comes that, okay, for 15 days, they are noticing this, or for last 1 month or for 3 months, they are noticing that something is coming in between their vision, and that is bothersome to them. Therein eccentric training would be useful. But by the time they are referred usually to low vision clinic after the treatment and all those things, and if say wet AMD and other patients, so it usually, when patients are reaching there, usually those things are developed. But there are reports which also suggest that those prism glasses and training doesn't help much. So there are contraindicating, or you can say that both having equal kind of so some are favorable, some doesn't show a significant difference. So some practitioners do it and do provide the care and eccentric wing training. So initially at LVP, we used to do it with the manual charts and other things. But recently, I don't observe people providing that eccentric wing training in the clinic. But there are people who also use microperimeter for that purpose, for plotting it and then training people on developing their PRL. So we have it in the research lab, but in the clinical practice, yes, as of now, we are not making use of it for training the person on eccentric wing.
Thanks, Deepak, for answering that question. I don't see any questions. Any further questions in the chat box? There's one, Sujay and Gopal, you're discussing. You want to quickly say what that LKC and you're talking about Metrovision for the audience. Sujay?
Hello.
Yes, Sujay. There's one question. Yeah.
Okay, let me. Okay, so LKC device is the late Crossfield and Cragg made device. It is US made LKC handheld device. It is basically for a screening purpose. On the other hand, Metrovision varies kind of systems as a tabletop. So where we are pretty much selective in terms of electrode placement. So there we use a contact lens, or we can also use LVP made ZD electrode. But the major point here, what we should consider, that is these are being used in tabletop system for evaluation purpose. We can justify the amplitude, height, implicit time, or latency time. But in a LKC, as we since we use a contact lens, we do not use a contact lens. We use sensor strip skin electrode. So the amplitudes, if it is like 100 micron, because of the sensor strip skin electrode, it goes down to 70 or 60 micron because of the placement of the electrode over the skin. More towards the cornea, that one point that we should cover up here, more towards the cornea or over the cornea, that would give you more amount of amplitudes, and as well as precise implicit time or latency. Because there is in normal situation, there is a action potential, that is the corneoretinal potential. The cornea is considered to be a positive and retina is considered to be as a negative. So if we place the positive electrode over the cornea, the response would be much better compared to the electrode which is being placed away from the cornea. That is what sensor strip, that is what the LKC and Metrovision tabletop system that differs from each other.
Okay, thanks, Sujay. And with this, we'll come to the end of the case presentation. And thank you, Soumya, for bringing the Stargardt's case presentation to the C2C platform. And we also thank Dr. Shrikant Kumar Padi for joining for the panel discussion, and Dr. Deepak Kumar Bagga and Sujay. And thank you so much for joining for this session.